It's a local joke. Let's be honest. We never
Mm.
expected it to work, and it was just more of a let's do something. But it's not made an iota of difference, not a dent in the production, and it didn't help that
Mm.
because the Supreme Court ruling said go ahead and burst firecrackers, and everyone just went wild. Honestly, it made me bad.
Mm. And Anand, I have a feeling that today's viewership is likely to be good. There might be people who would want to be online and they cannot get online. So we might be live streaming on the YouTube also and probably share the
Okay,
recording with them. Because
sure, sure.
I realize a lot of DNBs who want to gather information from the right people, no, they've been buzzing in different forums. So Kalpana is trying to put it online on the YouTube, but we also will try to see to get it across because one of those common topics, which people feel there's a ceiling there, and now once they hear to you, so it will be easier for them to take the discussion, even if the case comes airway surgeries. So
True, true. Well, sure. I don't mind. Thank you.
uh,
As I said, I'll share my experiences and what's going on currently in this field
and
because
for
it's
them
not
to take the discussion, even if the case comes airway surgeries. So
true, true. Well, sure. I don't mind. Thank you.
Dr. Subramanian,
As I said, I'll share my experiences and what's going on currently in this field
and
because
for them to take the discussion, even if the case comes airway surgeries. So
true, true.
oh God, there's a lag
Sure.
behind.
I don't mind. Thank you.
Dr. Subramanian,
As I said, I'll share my experiences and what's going on currently in this field
and
because
lot of echoing going on.
yes,
Take the
yes.
discussion, even if the case comes airway
there's a
surgeries. So
YouTube, oh God, there's a lag behind.
I don't mind. Thank you.
Dr. Subramanian,
As I said, I'll share my experiences and what's going on currently in this field and because
lot of echoing going on.
yes, yes.
Even if the case comes airway
I know
surgeries. So
where it is open. YouTube, oh God, there's a lag behind.
I don't mind. Thank you.
Dr. Subramanian,
As I said, I'll share my experiences and what's going on currently in this field and
okay. देखो आप
I was afraid we were going to drive a lot of people away by this loop. I was getting bored myself of listening to me.
ठीक है.
I think stopped. I think it was trying
Yes.
to on the net probably.
Okay, bye. So we are good. We are live on YouTube as well. And that was the YouTube playing in the background. I'm sorry, I didn't switch off the volume of it. My apologies.
We'll, Kalpana, it's 8 o'clock. Shall we wait for two more minutes?
Two more minutes or shall we just start?
We'll wait for 2 more minutes.
Sure, sure.
Sure, sure.
Because the normal habit is right on time, just on time. So
And how are you doing, Subra?
it's been a good last few months. So I'm starting to, because I was exploring the new, moved to a new institution. So the setting up of the units also is something which I'm learning. I've learned now. So there's apart from clinical material, small things about ACs and location of ACs, other things, buying new equipments, all those things have made it interesting.
For Olympia
Definitely.
Lawrence?
Mark.
That must be very
I'm so
exciting.
sorry, honey. The Earth is showing red late.
Take your time, Olympia.
So it must be very exciting now, seeing it all
It is
grow up in front of you.
every day, a few times, excitement keeps coming. But interesting to see that we've started to do a lot of robotic cases.
Okay.
I have never had robotic neck surgeries. Our surgeons are now doing robotic neck surgeries. So it is something new domain for me. So other things are fairly used to, but robotic thyroidectomy we had never done. So something new which making us read, adapt, and maybe I should be in conversation with you a bit more often.
I must say, you'll gradually find once the excitement wears off of the robotic head and neck business, you'll find that it tends to be, it's like watching paint dry. But the good thing that I find in that sort of situation is that you can get a lot of work done otherwise.
Yeah.
Because unlike other robotic surgeries, there's not a lot of things happening on the surgical field.
Dr. Kalpana, shall we kick off?
Yes, let's do that. Dr. Sharma, with your permission, I'll be recording this meeting.
Sure, sure. My pleasure.
So good evening, everybody, and I welcome you all to the webinar of Association of TIVA TCI Anesthesiologist. And it's my pleasure today to have with us Dr. Anand Sharma, who's going to take us through his TIVA experiences in upper airway surgeries. And we have Dr. Subramanian Mahankali with us. Everybody knows him. He's our president. And I would request him to kindly introduce Dr. Sharma.
Anand, shall we have your first slide? While I talk about it, I can start sharing the screen.
That is a good idea. Let's
So,
do that.
Anand, it's a great pleasure. We can have your that intro page, Anand.
Okay, I'll have to look for that. Just
No,
bear
no.
with me. Bear with me. Now you know where I keep my stuff.
No, I'll share some personal exciting things about Dr. Anand. So he's one of those silent people who knows everything to everything. If you look at his CV, it's very envious. So he has graduated from the best colleges in Delhi, did SR in Institute of Medical Sciences, Delhi, then went to UK, and currently working as one of the directors of anesthesia at Medanta, City, one of the institutions. Now, what also excites me is not just about his qualifications as an individual, one of the persons I have met, and
Hello? Subra, I think you muted your mic.
oh,
Hello? Can you hear me? Sorry. Hello, can you hear me?
hello.
Yes, I think your mic was muted.
Oh, sorry again.
It's okay, don't worry.
Am I audible?
Yes, quite so.
It's a great honor and a pleasure to introduce Dr. Anand Sharma, who is currently the Director of Anesthesia at Medanta Medicity. What excites me the most is that he is a fantastic person, fantastic friend. He's graduated from one of the best medical colleges in Delhi. He did his SR from AIMS Delhi, worked in UK, and is now a Director of Anesthesia at Medanta Medicity. As a person, he has got a very envious CV. But if you go close to him, he's such a wonderful person to interact, wonderful person to understand things from him. And you look at his special interest, even communication skill is there. There are more things than what is obvious from him to learn. Dr. Anand, we want to learn as much as possible within this 1 hour. Please take us through, and the stage is all yours. Thank you.
Thank you, Subra. That's most kind. Most kind. So I'm Anand Sharma. I'm one of the directors of anesthesia at Medanta Medicity. And over the last couple of years, my interest in TIVA has actually grown exponentially, more so since the advent of remifentanil. And part of it is because I tend to do a lot of airway work, a lot of airway surgeries, and TIVA, and that is a boon. And why would that be? Well, first of all, you're sharing the airway with the surgeon, and every time you use a volatile, there's always a problem about maintenance of anesthesia. You're really worried with a high surgical stimulus that an airway surgery tends to entail. Is a patient conscious? Then, of course, the presence of TIVA makes the emergence so much easier. So there's a lot less coughing. These patients who may wake up with sore throat otherwise, and with laryngeal surgery, they often tend to have a bit of edema as well. With TIVA, it tends to obviate a lot of that. So their waking up experience, particularly the first hour, which is very crucial for all of us, is much better than with a volatile anesthetic. Now, which situations would we tend to cover? Which situations would I be covering today as well? So we're looking at flexible bronchoscopies, which would be interventional. Interventional would be a typical difficult airway, or a tracheal stenting for that matter, or a simple diagnostic like the EBUS, the ultrasound guided biopsies that pop up now and then and are presented across to us. Then there's obviously laryngeal surgeries, all those vocal cord biopsies, the polyps that need removing, the papillomas, and tracheal surgery. Part of the tracheal surgery that we've discussed would be part of flexible bronchoscopies. I'm not covering open tracheal repairs because that would be a different ambit. That's a whole new ball game. But yes, we tend to use TIVA in that as well, particularly because there is going to be airway discontinuity in the middle of surgery. So TIVA tends to be a heaven sent boon, because otherwise you'll end up waking the patient up because there's going to be an interruption of the volatile anesthetic. So I'm going to discuss what, as in the drugs that are commonly used and the doses that are floating around, then the procedure itself, how do you go about doing it? And subsequently, what we'll do is we'll go over a couple of videos so that you get an idea of what I'm actually doing it. I'm not saying it's perfect because we all develop as we go along, but this is what is working for me currently in the scenarios that I'm presented with. Of course, there are caveats, there are cautions that you need to use, particularly when you're doing airway work in the presence of a strong sedative or a hypnotic, and we'll discuss those as well. So let's look at the simpler things first, the bronchoscopies, be they diagnostic, therapeutic, or simply for intubation. What do you need for a bronchoscopy? You need a patient to be sedated so that they're tolerating whatever's happening to them, which means that they should not be asleep.
Dr. Sharma, we are not able to see your slides.
Really?
No, I've already made you this thing. Will you share it again?
Let's do it again. I'll stop sharing and then restart.
Please do that.
Kalpana, it was available for us.
Oh, is it? I'm not able to see now I'm able to see the slides.
Okay. So do you want me to go back to the old ones?
No, please go continue.
Just go ahead. Just continue.
Okay. So for a bronchoscopy scenario, you want a patient to be sedated, so not distressed, tolerating whatever is happening to them, responding to verbal commands, because as you've all noted with remifentanil, it's very easy for them to become bradypneic, especially if you add on more hypnotics or more sedatives to remifentanil. So it's important that they keep responding to verbal commands. And of course, we need cardiorespiratory stability. When you're actually doing it, the bronchoscopy yourself, or you're in the OT, you don't really want to be bothering about hypotension, bradycardias, and apneas. We have a gamut of things available as far as infusions go. Previously, they used to be the old fentanyl boluses, and of course, Dexam, which is very popular and still works at all times. However, I have tended to stray away from Dexam because it tends to take a bit of a time to start working. And of course, at the end of surgery, in my experience, it takes around 10 to 15 minutes for the patient to be fully awake. Fully awake as in conscious compos mentis, because I want them to be eating and drinking as soon as possible and then going on their way. So the commonest thing that we started using, especially after COVID, because we stopped nebulizing patients for bronchoscopies during COVID and we stuck with our new regimen, was a propofol infusion combined with midazolam and fentanyl. So it worked fine, but bear in mind, as we'll discuss, propofol has its own set of challenges. It's very easy. It's a very moody drug. It can either knock out the patient if you're not watching carefully, or They're over there and they're still struggling when the bronchoscope goes in. So we've now moved on to remifentanil plus or minus a hypnotic added on to it. This is a study which looked at a group of which has been using remifentanil for bronchoscopies for a long time for very fiber optic intubation. The interesting thing to note in this is that, let's see if I can find a pointer there, is look at their TCI target doses. They're using a doses of 5 Remi alone, and they tend to go on a slower dose, sorry, on a lower dose if they're using midazolam along with it. This is interesting because, as we'll see, this is the standard DAS algorithm. This is their recommendation for awake fiber optic bronchoscopies, and they say that if you need to sedate, you do it with a target not crossing 3. And this is with you working alone. If you've got a assistant with you, then you may consider midazolam. So the experience of lots of bronchoscopies with a target of 5 is very interesting. Although, as you can imagine, if you're working with a target of 5, you're going to get a much better, uh, more relaxed patient. What about propofol? Since our transition, personally, I find it much smoother, but this was a study that formally compared propofol based bronchoscopies that were running with propofol infusions compared to those that were sedated with remifentanil. And the Remi concentrations they were using target was kind of hovering around 3.5, which is kind of within the formal legal range that DAS is recommended. While the propofol TCIs were not surprisingly 1 to 1.5-ish, which is what I would suggest, which is we all agree is perfectly normal. This is where a patient would respond as well. Interestingly, here's where the things get uh, really focused. The experience of the operators was much better with remifentanil. Now, this is their endoscopy score and this is their intubation score. And in all of these, from 0 to 5, a lower score would mean a better experience. And as you can see, the Remi group has lower scores for endoscopy, so the procedure itself was easier and the patient tended to cough less, which is not surprising because an opiate is always antitussive. Having said that, patients remember their bronchoscopies if they were given a Remi infusion compared to those who were given a propofol. But honestly, if I'm performing an awake bronchoscopy, if a patient is getting a diagnostic bronchoscopy done, it doesn't really matter because they're only getting sedated. It's not a surgery that's being performed, so that wasn't too much of a distress, which is unsurprising. What about airway surgery? What drugs in the armamentarium do we have for that? Remember, with airway surgery, with laryngeal tracheal surgery, you're actually looking at a different endpoint. You want the patient to be knocked out, so to speak, totally asleep and immobile. Now, this is something that has come up because a lot of people are now turning towards spontaneous ventilation during laryngeal surgery. We'll look at that in a moment. But basically, as we'll see in the video as well, it's very crucial that when they're actually pointing the laser dot and firing it at that point, if the cords start to move, then it becomes a big problem. Of course, the old caveat of cardiorespiratory stability still holds. You have a lot of things to worry about when you're starting a TIVA, when you're maintaining a TIVA. You've got other things to worry about. On top of that, when you're looking at an airway being operated, in addition, you don't really want to get your hands full with an unstable patient. Booth and Vidhani have been working with the Head and Neck Anesthesia Society for a while, and they've been big proponents of the strive high technique, wherein they use a high flow nasal oxygen mask to anesthetize patients for laryngeal surgeries using propofol tiva with a remifentanil infusion. Now, bear in mind, look at that dose. It's 0.05 mics per kilo per minute. This is low by my standards for airway surgery, but then they're getting away with it because the patient is breathing spontaneously. If they were to use a higher dose of that with propofol, the patient would be apneic, which is what I would do, which is what I tend to do. So they start off slowly, gradually. They try and maintain a end site and plasma concentration of 1, which gives them a graded hypnosis. So start off with 3, which is when a patient loses consciousness, move up to 4, where they tend to put in an airway, typically a nasopharyngeal airway, because if they put in an oral airway, the surgeon has got no place to work. This goes up to 5 and then to 6, where they would spray the cords. This is crucial. If you're choosing spontaneous ventilation for your anesthetic technique, it's very important that you spray those cords, otherwise they're going to start coughing. And with REMI, if with TIVA, I would say, if the cords are not properly anesthetized, either with a high dose of an opiate like REMI, or with a relaxant, or with a local anesthetic, then you run the risk of a laryngospasm, which is pretty nasty, because we know REMI can cause muscle spasm. And finally, they go up to 7, which is when the suspension laryngoscopy and the formal surgery takes place. They report not a lot of complications. This has been working well for them, and interestingly, they've not had any laryngospasm so far. Although they've had to take over the surgery, interrupt the surgery and take over the anesthetic, give bag and mask, support ventilation now and then. This has been further extrapolated to children as well, which is interesting, and which honestly, children breathing spontaneously for an AVS surgery are far safer than those given a relaxant. And in this, they actually compared their practice, another group compared their practice with sevoflurane. They used a propofol TCI target of 3.5 to 4.5 PEDS users, not surprisingly, and were running a REMI dose slightly higher, so 0.06 to 0.08, which is still lower if I were to use it for AVS surgery on its own. They targeted a base of 40 to 60 and were looking at respiratory rates of 10. So this is what they were using to guide their REMI actually, or at least a 50% reduction of the baseline respiratory rate. And we're getting good results. In this particular group, they actually added ketamine to the mixture. So they got away with a lower dose of propofol, a higher target of remifentanil, with a spontaneously breathing patient. Interestingly, they used BIS, but they said they could not find it very reliable, which is probably because they're using ketamine. And they added midazolam to it, so that does add to the potential danger, because the more cocktails you add in a patient who's breathing spontaneously, the more chance you're tipping them towards apnea. And they said they had CVS stability because of ketamine, and because the one component that is CVS unstable in this, big time unstable, propofol, was kept at a low dose. This is another study looking at remifentanil in pediatric bronchoscopy. These patients were knocked out with propofol running at a standard infusion. They did not have monitoring for depth of anesthesia. They used Remi at 0.2 to 0.3 and propofol. These are pretty high doses. And they were actually looking at surgery and hypoxia. These patients were not spontaneously breathing, and they found that those that were given an inhalational agent actually had more episodes of desaturation. I think that is probably because a greater interruption to surgery took place in this. Now, speaking of pediatric and total intravenous anesthesia, we do bear in mind a lot of times a child is actually going to come to the OT without an IV line. Now, ideally, this would be considered a contraindication, but these days the opinion is gradually changing. You can secure an IV line under a halothane or a sevoflurane induction, but you do need to bear in mind that the initial doses, the initial peak, the initial plateaus has to be lower. Otherwise, you'll end up over sedating a child, over anesthetizing a child. Especially if there's sevoflurane in your tubing and you're running remifentanil at the same time, it's a disaster for bradycardia. The commonest modules we have available would be ped fuser and Kataria, both catering to different subsets. I find ped fuser slightly better because it has got a bigger range. If those are not available in a TCF, I'm sorry, I was trying to copy it from the paper itself. Then there are two things that I personally would recommend. One is McFarlane, which again, pretty much like Kataria, targets slightly older children. And as you know, the infusion rates for these tends to be staggered over time. So if you're looking at milligrams per kilogram per hour, if you start off with 15 and then progress to 10 to 9 every 10-15 minutes or so. For smaller children, there's the Stewart protocol, which you can see has a smaller dose range, milligram per kilogram per hour. And this is actually quite simple to remember because it tends to run in tables of three if you think about it. If you compare these with the standard Pete Fuser and the Kataria model, so this is the comparison of these two with the Kataria models. As we've just discussed, the Stewart would actually have lesser projected target site concentrations, while the McFarlane model, which caters to older children, would comply with the Kataria model. Compared to the Pete Fuser model, the McFarlane model gives the patient more propofol, and the Stewart model gives the patient less propofol, projected propofol, based on the calculations. Now, these other drugs, so I would say propofol and remifentanil would be the stay. If I don't have these available, then I'd move back to dexmedetomidine if I'm using a bronchoscopy. But for general anesthesia, you need a hypnotic. So propofol is not going to go away anywhere. How do you go about doing them? How is it practically possible? Remember that when you're doing an airway surgery, there's already a lot of cognitive load in the OT because you're worried about the ventilation, the oxygen concentrations, the monitors, what's happening in the airway. Are they actually soiling it? Are they going to fire a laser right now without telling me, which happens with a lot of surgeons? Suddenly you'll hear the buzzing of the laser and you'll realize that they've not told you, so the FiO2 is still high. And if you add the infusion pumps, you need to look at the TCI, you need to look at the BIS as well. So it's very important that you don't work alone. This is the DAS recommendation for the OT layout in case you're performing a bronchoscopy or conducting a bronchoscopy, where as anesthetists you tend to stand at the head end with our staff around us, with our technician. This is one where you're actually going to stand at the side, and in this we tend to stand at the head. And this is what is most popular among anesthetists because we are used to performing a bronchoscopies from the head end of the bed. But in all of these, note that they recommend a second anesthetist standing at the foot end by the pumps. So they're the ones responsible for controlling the concentration of Remi or propofol or whatever you choose, and also monitoring the patient while you're busy at the head end trying to get the airway secured. If you're looking at a general anesthetic, if you're looking at the next step, which is airway surgery, this is the conglomerate we tend to have in our OT. A lot of surgeons, we have two teams. One surgeon prefers to stay at the head end with the anesthetist at the foot end because he needs all his instruments and his monitors around. If this is the sort of scenario, then we tend to keep our jet ventilator next to the surgeon because it doesn't have a long tubing. And next to the jet ventilator would be one trained anesthetist who is actually going to be responsible for it. The second anesthetist would be at the foot end with the pumps, with the machine and the monitor. Far simpler, although seemingly more cluttered, is if you have the surgeon at the head end and the anesthetist standing behind him. So you have the monitor at both sides where you can have a look. You have the jet ventilator next to your machine. You have your pumps nearby and the assistant and your backup all next to you. So this would be something that is equally ergonomical and easier to use compared to separated by the surgeons by the length of the tubing. Now, the official recommendations would say that if you're working on your own, remember, on your own would mean you at least have a bare minimum trained technician with you, technician who's trained in that OT for airway work. If you do not have a trained technician, then you ask for one. I would generally stop my list if I don't have someone that I can trust, because you can't be doing all that work yourself. So if you're having one trained technician and you alone, then the recommendation is that you only run one infusion, either Remi or dexmedetomidine, and you try not adding anything to it. If you have two operators, then yes, you can run two infusions and add things as you like, because one person is going to be dedicated looking at the patient's vitals and monitoring the infusions. The one thing that, of course, you'll all remember, but juniors might forget, is that your IV line is crucial. And in airway surgery, the hands are strapped by the side. You're away from the head end, away from the crucial areas of the patient. If this line gets dislodged, the patient is going to wake up. No questions asked. And there is nothing more horrible than a patient waking up in the middle of a laryngoscopy unintended. And if you're using a relaxant, it becomes far more terrible because they're awake and they're paralyzed and they're immobile. So guard your IV line, make sure you can see it at all times and you can access it. And if it's a long surgery, it won't hurt if you keep checking it intermittently or get someone to check it. Make sure it's not counted. It has known to happen. We're not living in a perfect world. Sometimes a drip tends to get disconnected. In our particular hospital, the claves, the trifuses are really bad quality. So we manage with connecting everything to a series of three ways, which tend to add a weight to the IV line. So you always need to keep an eye on that and make sure it's not getting dislodged or getting pulled away. Now, enough of the boring stuff. I'm going to walk you through the OT. Let's look at the bronchoscopy first. This is a patient who's scheduled for a major uh, oral composite resection with a free flap. We're going to do them under a totally intravenous anesthetic. So we start off with a REMI infusion. This gets connected as soon as we have an IV line in place and a three-way running. The infusion at the bottom is a NORAD infusion, which we may use, may not use. We have it ready because you agree in the middle of surgery, particularly airway surgery, the arms strapped to the side, you're not going to get much time to connect anything. So what I personally tend to do, the TCI pumps in my institution are limited. There's a So if I get a TCI pump, I reserve it for propofol because it acts as a second line of defense. I have a BIS for monitoring depth of anesthesia. If I add a TCI pump for it, it becomes kind of foolproof. Remifentanil, I tend to manage without a TCI pump because it's not for hypnosis. I can get away without it. Now, the other thing is the doses I tend to use for Remi is around zero point 0.2, at least zero point 0.2. That is what is going to secure immobility, the anti-tussive effect on the cords. Below that, it depends. Sometimes it might work, it might not, but for most things, the first attempt is the best attempt. So if once I've secured the tube, then I can play with the Remi and bring it down. But till then, it runs at zero point 0.2 mics per kilo per minute. Now this is Remi running at zero point 0.2. The NORAD at the bottom, the TCI pump with the propofol connected but not started yet. And we've got the rest of the monitors connected, including the base value, which is over there. And the uh, bronchoscopy is started. So before this bronchoscopy, we spend around 5 minutes with this Remi running at zero point 0.2 so that the patient gets a decent level of Remi inside them slowly. As you are all aware, if you start getting impatient and we start purging Remi into patients who are awake, we land up with bradycardia or apnea or both, which is not a very conducive experience to the anesthetist health. So this is the 10th minute after starting Remi. As you can see, they're awake. We are paroxygenating the patient with the anesthetic circuit because we've got a trained assistant available and we have enough hands in the OT. This is 8 o'clock in the morning. And the other anesthetist in this case was me. I was standing at the foot end watching the pumps and watching the patient's breathing. This is the head and neck OT where the surgeon likes to stay at the head end. So we are near the cords. As a habit, we tend to spray them before going. Although, in my experience, if you have a dose of zero point 0.2 and above of Remi running, then you can get away without it. But it's always a good idea to spray the cords. What we really don't want is a surprise laryngospasm at this point. So the cords are there and we are going in through them. There is no coughing. So pretty straightforward. And this is all you need to do in case this patient needs a tracheal stent or a check bronchoscopy or an EPIS. Once the tube is in, we start the propofol. We have a target set at 3 and it's going to go up. He's going to fall asleep. Then we'll start playing with the Remi and see where we can find the balance where they're immobile and relaxant free, because this surgery would need nerve stimulation in the middle. So this was the bronchoscopies. Now let's look at the exciting stuff, the laryngeal surgeries. So once again, patient comes into the OT, we attach the monitor, sign-in is done, we have secured an IV line, and we start remifentanil straight away at point 2. Now in this particular case, the TCI pump had been robbed by another OT. So we were using propofol using the standard infusion rates guided by the BIS monitor. So that's Remi running. Now we're going to start pre-oxygenation, which is going to run for around 5 minutes before we start doing anything to the patient. So after around 5 minutes of good pre-oxygenation, where the FiO2s, the inspired oxygen concentration is more than 90%, we start the propofol infusion and we start giving a bolus at the same time. We're looking at the standard 150 to 100 mics per kilo per minute start, and then maintain it to 100 and then titrate it further. Maintain it to 100 after induction after around 10 minutes and then titrate it based on the base. Now we've not given any relaxant. Since the advent of Remi, I've stopped giving relaxants in airway surgeries. Although rocuronium with Sugamadex is available. And we'll see why that makes a difference. So the BIS has started to fall. And because now propofol has been added to remifentanil, you can see the apnea. On Remi alone, they were breathing, but with the induction dose of propofol, of course, it takes away the respiratory drive. And we start bagging them. Once we're happy, we got a good depth of anesthesia and the jaw seems relaxed, which takes around 5-7 minutes. I mean, you can cut corners by doing a laryngoscopy 5 minutes after you started Remi and in the middle starting propofol. You can if you're in a hurry, but then we tend to take things more relaxed because we need the lungs full of oxygen. So when everything is nice and relaxed, there's the laryngoscopy happening. We always use a video laryngoscope in a laryngeal surgery because the surgeons also want to have a look. And the patient gets intubated. So this would only be possible if you're running an infusion, in my experience, of 0.2. Below 0.2, there's a risk that the cord would start closing off and you get a laryngospasm at this point, unless you want to use a relaxant. Of course, if you want to use a relaxant, then it's a totally different matter. So tube is in, you started maintaining the anesthesia. This is 40 to 50. Now ergonomics, this is a view of the OT in the second setup that we discussed. In the previous setup, you've seen that the machine was at the foot end and the anesthetist at the and the surgeons at the head end. In this particular setup, this is the second setup where everything's at the head end. This is, as you can see, it seems a bit cluttered, which is why some surgeons don't like it. But if you plan it correctly, everything's in front of you. So you got the surgical team over there. The good thing is you can always push them aside and bag and mask the patient if anything goes wrong. You have the jet ventilator with its controls right next to you. You have the one patient monitor at the head end, there's another one at the foot end, so everyone can have a look. There's the Conox monitor in this case. Then the anesthesia machine is right at your right side with the infusions running over there. So it's all within easy reach. Now back to the MLS again. This is the maintenance patient. I tend to personally put them on SIMV because I'm not using a relaxant. So in case there's any bit of breathing, it gets synchronized by the machine. So there's no coughing. So again, Remi is still at 0.2, while propofol after 10 minutes, we'll start bringing it down. I think this is where we start bringing it down anyway. Generally, that tends to happen after the scope is gone in because that's where most of the stimulus is going to come from. This is the surgery. They've exposed the larynx. This is where the immobility is vital, which you will get with a high dose of remifentanil, and your hypnotic. And if your patient is breathing spontaneously, this is where the cords move. There are surgeons who prefer to work on moving cords. Our surgeons in India mostly are not. They tend to get very worried if a patient moves a finger. And this is the other thing, the importance of immobility. He's firing the laser. If the cord moves at this point, he's going to hit something else. You can see the pack there, which is protecting the subglottis and making sure that there's no airway fire. At the end of surgery, what we tend to do after doing so many of these is, as soon as the laryngoscope, the microscope is disconnected, we stop the propofol, because as you're aware, propofol would take around 10 to 15 minutes to vanish from the system and for the patient to start waking up. The BIS in this case, because it's a laryngoscopy, I would tend to maintain it at a lower level compared to standard surgery. So it tends to be around 45 to 50 if the uh, vitals permit. So if a patient has got a heart condition and I'm having struggle maintaining the blood pressure, I would of course try and keep a higher BIS. But with the laryngoscopy, we tend to keep them deeper. And when the suspension laryngoscope comes out, which happens about a minute or so after the microscope is out, because after the microscope's been removed, that's when they do the final hemostasis, suctioning, so to speak. When the scope comes out, that tends to be a time for stopping the REMI, because it takes around 5 to 7 minutes after this. We keep watching the BIS, which is going to rise very quickly after this, because the propofol has been stopped earlier. Now, this is the crucial part, which is why I love REMI and I don't like relaxants anymore, because once you stopped REMI, the extubation tends to be much smoother. There is less trauma to the cords, there is less discomfort to the patient. And here's a trick I learned from other experts. If you're using a REMI infusion, you don't wait for spontaneous breathing and return of reflexes to extubate a patient. You wait for the patient to wake up and respond to commands. So you start waking them up. If they're opening their eyes, that's your cue to start extubating, because if you wait for everything as a standard neostigmine reversal to happen, then there's a lot more coughing. Then it starts, as you can see. So if you pause at that time, there's a lot more coughing going on. Having said that, don't try it at home. Don't do this straight away. Get into the habit of doing it a few times. And then once you get into the groove, it becomes a lot easier. Okay, now I do have, if you have time, I've got a series on bronchoscopy for a foreign body. This is again us standing at the head end in a clutter. In this case, we have a second anesthetist who's intermittently ventilating the child, and because there wasn't a lot of space, we had the TIVA and the TIVA pumps at the foot end with propofol and remifentanil. And we're ventilating the child intermittently with a jet. And because it's a small table, you can see what's happening at the foot end quite easily, and we're easily approachable. But again, as I said, there were two anesthetists and a trained technician with a surgical team who's used to everyone, so it was easier. Okay, thanks. I'm done with my presentations and I'm open to questions.
Dr. Anand? Oh, you had taken us to a different, you know, I don't know what we call it, a different domain where the technique, how you have used it was simply a lot of things were new for us. So I think we have got a very interesting set of people who have joined us. I mean, we can see Dr. Ramesh from Chennai, Kanchi Kamakoti. I could see Ilava Jadi from all the way from Toronto. All of them have joined. I think if there are any questions, we will take it from them. But I have a few things which I wanted to just explore and expand the topics understanding. Uh, uh, I can see that you have used a bit more propofol concentrations compared to other times. So, is that a common thing in airway surgeries? What is your experience in that?
So, you mean the propofol dosing that I'm using?
Yes, 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 yes.
Yeah. Yes. So, uh, what I have started doing is propofol would typically be used in a general anesthetic setting where there is a laryngoscopy going on. So, in the first 10 minutes or so of surgery, there tends to be a lot of stimulus on the patient.
Hmm.
And the other thing is that the surgeries that happen tend to be very short. So, you're right. We use a larger dose of propofol, so we obviate the stress of our own laryngoscopy, then the surgeon's suspension laryngoscope, and then start tapering the propofol concentration down gradually. Because once things are set, then we start playing around with them. Unfortunately or fortunately, by the time we're actually halfway through our playing, the surgery is over. Because a lot of these tend to be over in around 15 to 20 minutes. So that explains the higher than normal propofol that you're actually seeing in your screen, because we've not had that, that 10-15 minute interval to bring the concentration down.
Kalpana, can I ask one question?
Yes, madam, please.
Please, madam.
Yeah. All these airway cases, do you give anticholinergic like glycopyrrolate beforehand?
No, not anymore. Not anymore.
But if there is a
So
bradycardia, how would you?
if there is a bradycardia, we'd react to it immediately. And the common bradycardia we would see in the odd patient would be someone on a beta blocker with a laryngoscope. So with a suspension laryngoscope, someone on a beta blocker. But we don't prophylactically give uh, atropine or glycopyrrolate to everyone. There are two reasons in my practice, in my opinion. One is that once I have a patient who is running a heart rate of 100 on table, then what I personally feel is I've lost a monitor, because a heart rate for me is a monitor as well of the depth of anesthesia of what's happening to the patient. The second thing is that it causes a lot of dryness. And if you're using a jet ventilator for a short period, or particularly with laryngeal surgeries, at the end of the surgery, the commonest thing the patient complains of is a sore throat, which is itchy, which is dry, because of the surgical manipulation. So on top of that, if I add the dryness of atropine, then it increases the discomfort further. So I would definitely recommend it if I'm planning a bronchoscopy. If I'm planning to intubate a patient, then yes, I'd put in a glycopyrrolate preoperatively in while the patient is waiting in pre-op, but not for laryngeal surgeries. But then that is my opinion and my practice.
Yeah. Because when the surgeon, when the children come without IV and they start crying and they have more salivation, so would you like to give glycopyrrolate before
So
starting
it's
SIVO
in,
or whatever?
so so it's interesting. The foreign body, that videos that I showed in the end, towards the end. So the child came to the OT, had an IV secured in the OT. Now, because the child was distressed and had been starving, the first heart rate we found was 120, right? And then when the laryngoscopy started and the bronchoscopy started, we were managing the heart rate with remifentanil and propofol, trying to increase the depth of anesthesia, because the strong stimulus was increasing it even further. So if I had put in an dose the child with glycopyrrolate or atropine, it would have increased further. And in my experience, the anticholinergic driven tachycardias tend to be very tricky, not very amenable to increasing the depth of anesthesia. And as far as secretions goes, yes, he would have had secretions, but then the surgeons were suctioning the field continuously.
Thank you.
But then, as I said, madam, that is my opinion. Others may differ, which is fine.
Dr. Sharma, do you make use of if you're using a TCI pump, do you use the decrement time for getting your propofol off when you know the surgery is getting over, or you just
Yes,
put it
yes,
off and you just wait for the...
absolutely. I think that is a boon. That is why there is a fight for a TCI pump in our department. We beg, borrow, steal wherever we can, because that is heaven sent. At the end, once you've worked with the surgeon for a while, you know कि उनके assistant will take 20 minutes to close this incision, and that decrement time is heaven sent because it saves a lot of time. Although I might add, you must have come across this article in BJ. This was, I think, 2 months ago, where they were looking at BIS values and correspondingly extrapolating TCI values, target values, to elderly, to the geriatric population, and saying that maybe we are overdosing our patients anyway. And in my experience, most of the calculations, the protocols, the BIS values, and the TCI targets have been set for Western populations. The Indian subcontinent has a lot of opiate naive people. So, despite uh, the lag times and despite the decremental times at the end, our patients always end up taking 10 minutes extra to wake up.
Yes.
Which is fine. I think I don't mind waiting 10 extra minutes if I get a good reversal.
So actually, the rates that give us like 3 to 4 or 5 to 7 nanograms for remifentanil. Uh, um, I mean, in actual practice, I was just discussing with Dr. Subramaniam also. I don't think we need to use that high dose in our end of population, because that has been studies which has been extrapolated to the
True.
Western group. And I think Dr. Puri is the one who's actually brought about that lovely article for patients for cardiac surgery, and he has said that propofol of not more than 1 to 1.2 milligram is something which is required in a TCI pump. That's what his basic analysis was. So that kind of proves what you also concur with that thing, that we do not need such high doses of TCI target values for effect site targeting in the Indian subset of population.
Absolutely. Absolutely.
I don't know, in this context, I just want to share that, in recently in Nature, one of the articles has come wherein which they have focused on 3 genes which make people hypersensitive to propofol. And when it becomes a bit large scale, I would be very keen to see what is the distribution among the Indians and in a Caucasian population. I having practiced significantly in UK, used a certain dosage, but that seems to be more than what is required here. So that is so true, what you said, Dr. Anand and Dr. Kalpana. I think Dr. Ramesh is online. Sir, you wanted to ask any questions, sir?
Ronald, I'm happy that you could recognize me. So, thank you for that. But I'm very interested in this topic. We do a lot of airway surgeries in children now. It's quite like whatever you talked about adults. But I just wonder what type of jet ventilation you use. What is the jet ventilator you have? What do you use in that? Because in the bronchoscopy, I saw
Sir,
you
we
said,
have
what type, sir? What
so
jet ventilator you use?
it's a Monsoon 2.
Okay.
It's Medtronic's jet ventilator, automated Monsoon 2, which we tend to use.
Yeah.
We use this automatic. When we were looking for hunting around for a suitable jet, this was the safest in the market because it had automated cutoff values, so you don't really have to worry about uh, you know uh, barotrauma. So
Pressures. Yeah.
Yeah. Other, I just want to know my experience, whatever it in children, is that though I have both the real TCI pump, which is all the pumps, but I find for airways diagnostic procedures, I use TIVA for both propofol as well as for the REMI, not TCI, because you start propofol TCI, it gives a lot of initial bolus, which becomes very high for a child. So
absolutely,
I
agree to
agree with Dr. Puri, because I don't go up to 4 milligram per kilo. I give to 1 to 1.5 milligram per kilo of propofol just to put the child to sleep a little bit. Then I give a Remi of 0.2 mics per zero point 0.2. I use a zero point 0.2 and then wait for about 5-6 minutes and then do the spray. I think spray is the trick of the trade as far as the airway diagnostic procedure concerned. But if
true,
you're
true.
going for long procedure for laryngeal reconstruction or tracheoplasties and tracheal tracheopexy or iotopexy and things like that, we may put on TCI, but TCI may be propofol and TIVA with. So I just mix up with the TIVA and TCI with the propofol and Remi for airway surgery, and then because we have a control immediately to do that. Once you put a TCI, it's already targeted. It's difficult to come back to the normal level with the propofol.
Absolutely.
So I prefer a TCI for both than on target control, TIVA for both than a target control for propofol for airway surgeries. I'm not talking about the neuromonitoring and things like that. That's what we are doing maybe for all tracheal reconstructions, even tracheopexy and things like that. I
So,
prefer TIVA for airway surgeries than TCI. That's what my experience is that as far as airway surgery is concerned.
and I might add that in children using a TCI pump, you set up a value
Yeah,
and it starts giving propofol at its own merry rate,
yeah.
and the child starts crying because whatever you do, there's always that 20%, 30% people for whom propofol is painful. And I find that distressing, and everyone finds that distressing. You start an anesthetic, and the first thing the child does is start crying, compared to an adult who will not cry, who will just protest. Because the infusion rate, the bolus infusion rate of a TCI pump is different to what you and I would do if we were doing it manually. That is something that I find very concerning, especially, I think in another year or two, we may have 2% propofol coming up, which is what is the standard usage for TIVA. And that is even more painful to inject. And TCI with 2% propofol is pretty agonizing to begin with.
You mix with the lignocaine. You see, we always mix with
We
lignocaine, the
we
propofol.
we always mix lignocaine with propofol. The
Yeah.
problem is sometimes it doesn't work. It doesn't work in all patients.
You can combine with the CO a little bit. See, what I feel is that you can combine a little bit of CO, and it is not that it's, to my knowledge, a TCI or TIVA doesn't mean you should not use TIVO. CO is not contraindicated, so you can put a little of CO, about 0.5 to 1%, and along with that, give slowly little propofol, and then give Remi on the other side, and then wait for some time. I think the patients are it's an individual preference what
So,
exactly you want to do it. You just play with the drugs as long as it is very ultra short acting. You can put switch on, switch off drugs are there, which we are just modifying. This is my opinion. I'm not sure. Maybe put on TCI and then propofol and Tiva and Remi, what you have done before. I think that's okay. I don't know.
I quite agree. There's more than one way to skin a cat, and there's no. And I'm just answering this question. How do you suggest we go about doing these cases when there is no remifentanil available? So if there is no remifentanil available and you need to get a bronchoscopy done, then a Dexam infusion is a perfectly safe alternative. I find it safer than using propofol if you need to do a bronchoscopy done. If you're using a laryngoscopy or if you're using a direct laryngeal surgeries, then you can very well run total intravenous anesthesia with propofol with fentanyl. But my suggestion is you add a muscle relaxant to it.
Dr. Anand, when you use, say, dexmedetomidine, do you use it as a normal infusion or a target controlled infusion?
So far, I've used it as a normal infusion. I just scribble the bolus doses and the time I need to change the infusion in a small paper and run it as normal. I haven't used it as a TCI yet because since we got propofol and Remi and the TCI, we practically hardly start using Dexam again.
I strongly feel that now the newer pumps do have dexmedetomidine. Two different models have come, wherein which two different algorithms are there. I feel we have explored less of it. So I think it's an exciting way to use because one is administering, other one is helping you reflect on what is happening, titrating it to the levels what is estimated there. So I think there's a fantastic role for how we use Dexmed also. So I think maybe sometime in the future, Dr. Kalpana, we should schedule how to use dexmedetomidine both as a
Absolutely.
regular infusion as well as a
Sure.
as a TCI.
Yeah, I hand over Colin. Yeah, sure. Dr. Sharma, supposing these patients of what you said, bronchoscopy, which you just showed us, and if you had done found that it was a difficult airway, and could you just kind of go around, how would you go ahead with Remi in such patients? What precautions would you take?
So you mean a bronchoscopy for a difficult airway?
Yeah, if it was a known case of a difficult airway, how would you have gone about?
So with the um, most of the major OCRs that we tend to get, the ones who are needing bronchoscopies would invariably have a difficult airway. Now, as I said, precaution wise, of course, you get the OT ready. I mean, I'm not going to go into the DNB answer for that, but the staffing is vital because you need one anesthetist with you who's actually going to monitor the patient while you're busy with your bronchoscopy. The second is going to be a technician who knows what the next step is going to be, who's well versed with both bronchoscopies and a REMI. What we've done, because now we have this setup and we have the luxury of staff in the morning, we tend to combine remifentanil with midazolam. So the patient comes in, Remi is started, and they also get a dose of midazolam 1 milligram or so. As I said, we don't tend to, if the patient is in IV line, then pre-operatively before they come in, they tend to get a bit of glycopyrrolate, which is basically for our comfort. But if they're rushing into OT, then as you know, glycopyrrolate needs a bit of time to work. So that may not always be possible. But the thing of vital importance is for the second anesthetist to not look into the screen, to not do anything else except monitor the patient, talk to them if they're apneic, and monitor the REMI concentrations that are running. Look at the monitors, look at the saturation, provide oxygen wherever needed. Uh, if the patient is stridor, let's look at stridor differently in a moment, because the advantage with REMI is that if you get stuck, what you can actually come back pretty quickly, because in this particular situation you do not want a patient who's snoring. A difficult airway and snoring means you lost the airway. So it takes around, I mean, if they're snoring, even if they're snoring and you're running REMI or you're running propofol as we used to do, you can stop, they'll come back, but it takes a good 3 to 5 minutes for them to resume normal, and in that time their saturation might drop drastically. So you need to keep them, as the DAS guidelines proposed, at a level of sedation where they're responding to you, which is where the second anesthetist comes into play, that they're constantly looking at the patient and not taking their eye off. If the patient has stridor, then it depends on what the reason for the stridor is. In that particular case, although I've been to when REMI was first being used in the entry group in DAS, this was when the guidelines were coming out, then they were all for using REMI even during stridor, because they said if anything goes wrong, you can come back straight away. You can stop and the patient will reverse on its own. But it's always a touch and go situation. So I would follow the old dictum of probably not sedating anyone too much and then using blocks to secure the airway, or simply a surgical airway in that particular case.
Anand, I want to ask one additional question. You did mention extubation when you use REMI, extubation with REMI is different from reversing. Can you just expand a little bit so that we, all of us who have not used much of remifentanil, understand what is the best way to extubate them?
So, see, with a standard muscle relaxant extubation, you go through steps. Wait for the spontaneous respiration to return. Then you wait for the patient to regain their oropharyngeal reflexes and to open their eyes and respond to verbal commands, right? You have these three pillars. You wait for the spontaneous to return first, then you start progressing on to the other two. With REMI, remember, it's a very strong antitussive. So the return of reflexes may not be just as quick, but because they're awake, you're not too worried about them snoring or them aspirating at that particular point in time. So this tends to get, inverted. So with REMI extubations, the way I was taught was you wait for them to open their eyes and respond to verbal commands first. Once they've started doing that, you remove the tube and they start breathing on their own. And that's almost always, I wouldn't say almost always, that's always been the case that I've seen. Once they've opened their eyes after you stopped REMI, it means that they've come down to earth and they start breathing on their own. But in this case, if you use REMI as the old muscle relaxant way, which is return of spontaneous breathing, then opening eyes and responding to verbal commands, you lose the charm because then they start coughing. Return to oropharyngeal reflexes means coughing on the tube. It seems a bit counterintuitive, and as I said, you need trained assistant, someone who knows what the next step is going to be, and of course you need a proper patient for it. I might not do it in a full stomach patient who's come up for a perforation peritonitis repair, but I would do it in an airway case who I know is fasted and has no risk factors for aspiration.
Fantastic. Any other questions, Dr. Kalpana?
I think there's someone who mentions better access to pumps. I would say for if you have whatever infusion pump you have, you start using that. Don't worry about TCI. Don't worry about any flashy pump. Any simple pump that you have, you start using that for TIVA. It doesn't matter. But the crucial thing for TIVA that I personally find is that if you're using propofol, if you have a TCI pump, it kind of guards against awareness. You have a medical legal defense that I was running this according to a prescribed protocol, and patient is not expected to be aware. If you do not have a TCI pump and you're using a normal pump, then it is recommended that you have some sort of depth of anesthesia monitoring to protect you and of course the patient against the risk of awareness.
Maybe one final question, Anand, if I may. Now, the BIS monitoring, in what age groups you feel comfortable when it's not reliable? Any particular rule of thumb you follow?
Let's be honest, I've only used BIS monitoring for adults. We do not have BIS electrodes for children. We do not have the adapters and electrodes for children. So I tend to not use BIS in children just because it's not available. So adults would be anyone more than, in my opinion, anyone more than 40 kilos, I would be happy using BIS in them.
We just a few weeks back we had one of the neuroanesthesiologists speaking on this BIS. So he was suggesting that anyway, probably you can use it from age of 6 months. But obviously, that's not the only thing which you look for. You look for other cues as well. So, but it is reasonably okay if it's not an infant, where if you apply it in children, you get a reasonable estimate. I think that is something which all of us need to get experience on. I don't know whether Dr. Ramesh or Dr. Jadi is there. So, sir, you have any experience of using BIS in these young children, sir?
Thanks, Subra. We don't have a BIS monitor, but we do have EEG monitoring. So that gives you the composite of both the CSA as well as the SEF, spectral edge frequencies. So we can apply it. Obviously, less than 2 years of age, the frequencies are high. So you don't go with collectively with it, just looking at their SEF alone. So you need to have a good understanding of their CSA as well as their SEF. Yes, we do use it all the time, and we use total intravenous infusion anesthetic. I just want to add some few other points about the pediatric practices of these laryngeal surgeries and total intravenous anesthesia. So we do in Canada. I mean, we don't have the pediatric PCI model pumps, so we do heavily rely on infusions. But we've been doing that forever, probably more than 20 years or so. We've been always running propofol and remifentanil infusions and managing tubeless airway surgeries all the time. So it's sort of a second nature for us. They all go after sleep with a CO induction, get an IV. We'll start our propofol infusions and then Remi infusions at the same time. We don't bolus the Remi. We are sort of a propofol heavy Remi on a lower scale, somewhere between 0.05 to 0.08. And we primarily assess their ventilation based on their respiratory rate and parameter and pattern of breathing. But once you get to the depth where there's a very minimal diaphragmatic breathing, then you do your laryngoscopy, spray the cards, and then give it to surgeons to do the suspension laryngoscopy. That seems to work very well. Lately, of the last 4 or 5 years, we switched on to when the Dexmed came on the line. We started using Dexmed infusion. So it's either Remi infusions or Dexmed, or occasionally we might just give a little bolus of Dexmed alone without having an infusion of Dexmed. So some of the kids still may have either in spite of running propofol at 300, 350 mics per kilo per minute, may still have some degree of movement, in which case, and the rate of breathing may be very too slow for us to up the remifentanil anymore, in which case we might add a little bit of ketamine, like 10 milligram or so of ketamine. So that's our very much like a sort of a composite mix forever. And that seems to work very well. So we just don't seem to have any challenges. We also don't have a jet ventilator, so our patients are pretty much spontaneously breathing all the time, either for suspension laryngoscopy or whether they're getting bronchoscopy for a foreign body removal. So that's our practice too.
Dr. Subramani, just about the BIS, we were told for a long time BIS is not very useful in children. Over 2 years, it is unreliable, and so we have initially we bought and almost we have stopped using BIS for a very long time. And now the TIVA has come and TCA has come, and it has then we switched back again to BIS and see whether it helps in children. Though I told the values and all exactly matching what they're talking about, 50 or 60 or 40 or something like that. But I find that the trend makes a little bit of, gives some confidence that you can keep about 50 or 60. Okay, we can increase a little bit. And if it is about 30 or 40, I think we should reduce. I think that gives a little bit of a comfort level with the BIS. I can't tell you this is the level, what you have been done in the adults cannot be exactly extrapolated in children, though it is not exactly useful in children. But I feel that when we start using it, it becomes a little more a part of our TIVA TCI, so that it gives us some comfort that this is how the level of, so we can proceed with that. So I can't really tell my statistics because it has not been really done, but I found it very useful for my own sake, that you can use a little bit of a common sense to know the BIS levels and adjust the dosages according to that.
Sir, so true, sir. As you said, it's not just the number. You can also look at the trend. And quite a few times it has happened when I've used invariably. Sometimes you tend to be focusing to get the BIS number down. That has led to burst suppression, etc., which we realized after looking at it very closely. So I think if you look at it as more as a trend indicator, it has got a bigger role. I'm so thankful that you brought up that topic, sir. Thank you. I also want to thank Dr. Ilivajadi Srinivasan, who is one of the consultants in Sick Kids Toronto, for joining here. And Dr. Kalpana, you want to take up any questions, or are we done?
I just wanted to know, Dr. Sharma, do you use any of these awareness questionnaires that we have for either for pediatrics or for an adult to look out for awareness after the procedure, if at all we do not have the BIS or any monitor? Have you any experience on that?
No, actually, as far as post-op questionnaires go, that tends to run in periods where we're doing a bit of quality improvement projects, but not regularly. And as I said, most of us would use TIVA if we either have BIS or Conox available or a TCI pump available. If we don't have any of these three options, then we tend to not use TIVA.
Okay. Okay. I think I'd see no more questions. Dr. Subramaniam, maybe call it a day.
Yeah, I think ever enterprising Dr. Kalpana for organizing all this. I'm so thankful that a person like you is leading the webinars of Aotta, which the society which you have formed to gather together, learn more from each other, and expand the scope of safe practice of TCI TIVA in India. He's also manages the DNB series as well. So kudos to you, Anand. I can't believe that we have missed you in this loop so much, and having so much experience. Generally, as anesthetist, as a person, and in the TIVA field, we want you to be more active in the group and share your knowledge and expertise, because you are working in one of the best centers. We want to hear more from you, and all those who have joined, whether Dr. Ramesh sir, Dr. Jadi, and I've seen quite a few senior names here. I don't want to go each and everyone. My heartfelt thanks to all of you, and what better way to end a day. So we have learned a lot, and we keep reflecting, and we'll grow together.
Thank you so much. Thank you for having me.
Thank you, Dr. Sharma. We will reach out for some more topics, and I'm sure you'll accept it. Thank you so much.
I must warn you, I'm a very lazy person.
We'll shake you a bit.
Thank you.
Okay, good night, everybody, and thanks for joining tonight. Thank you.
Thank God. Bye. Have a good day.
Bye-bye.
Bye.